Hi, everyone. Welcome to our session. I know we're right at the end, so hopefully we can get some energy up. My name is Kelly Davis. I'm the Associate Vice President of Peer and Youth Advocacy at Mental Health America, a national mental health advocacy organization in the U.S. And we're going to be talking about the mental health of the healthcare and mental health workforce. So before we get started, we're going to talk about a little bit of the challenges, but then also a model that has really great solutions for how to change culture at a time where people are really struggling and there's a lot of need. So to get started, we're going to have everyone do an activity. So our question to open it up is we're going to be talking about creating empowering environments. So describe a time, find someone who you don't know or you haven't talked to, and introduce yourself and describe a time where you felt empowered in the workplace or school. So any experience is relevant here. Or you did something where you felt like you empowered someone else. So I'm going to give an example, Peter's going to give an example, and then we'll give you a little bit of time. So for those of you who are familiar with Mental Health America, my example, our previous CEO was named Paul John Frito. And I actually got hired at MHA the day of my college graduation party, which was really great because I got to go and say I had a job on it instead of people being like, what are you going to do? So that was wonderful. But I've been there the whole time. And Paul actually was elected to public office when he was like 25 years old, which is amazing. And he had a really deep belief in the power of young people. And one day, I was a youth activist and saw all of these problems, and I didn't really see, I saw a gap on the national level of things that we could do. And he had an open door policy. I'm like 24 years old. I'm like, hey, Paul, can I come to your office? I came in, and I said, here's the problems. Here's what I think we could do. And he said, okay, you can have 10% of your time and just work on that. And I was like, oh my gosh. And it gave me so much confidence in myself that somebody who I felt had decades of experience and all of this wisdom believed that I could understand something that was my own experience. I think when you're a young person, just being heard before, you're often made to feel like you don't understand your own experience and don't have anything to contribute about it. And I think that really changed my whole life, and I also now really try to embody that in working with other people. So I think just for me, empowerment came from somebody taking me seriously as someone who was kind of used to maybe not being taken that seriously by people in power. And I'll turn it over to you, Peter.
Thank you, Kelly. So I'm going to start first by saying that I have lots of conflicts of interest, and I like to say that because in leadership we need to have connections to a lot of different organizations, and so I say that with pride. I am a retired faculty member from an East Coast university in Canada, still doing research for that university. I'm the founder of a not-for-profit called Step Care Solutions, which is the lead administrative partner for a population health program that offers a wide range of supports, including free access 24/7 to counseling, along with peer support and other programs on a stepped care continuum. And I am leading a student mental health center at University of California, Berkeley, where we're really trying to learn how to develop this model of care even further with the talent that is often available from students, faculty, and the surrounding community in the San Francisco Bay Area. But first of all, and before I share my story, because it's relevant to my little story that then you will have a chance to discuss at your table, I'm struck by the two words, learning and leadership. They both begin, and this is important to remember, they both begin with L-E-A. And leadership is all about learning. And I think sometimes leaders forget that. And so part of the reason I'm at Berkeley is because I have so much to learn still about how to do leadership, how to transform mental health systems. And so this story that I just want to share for you is actually from the first in a series of 3 books on Stepped Care 2.0. I'm often invited into training programs or universities or health systems, to clinicians and leaders, to talk about this model of transformation. So I just spent, I think it was about 40 minutes talking about this model, Stepped Care 2.0, to a psychiatry team at a West Coast Canadian university. And so at the end of the presentation, I noticed, I'm just reading from the book, a wide-eyed stare from a psychiatry resident as she listened to me describe the model. There was a moment of stunned silence before she said bluntly, but without any judgment, "Everything you have said today contradicts all that I've been taught during my psychiatry residency." While she seemed shocked, I noted an element of wonder and curiosity in her tone of voice. Something clicked. Emotion was aroused. And these are the kinds of moments that I think we need to capture to mobilize change. And so leaders, as leaders, that's our job, is to help bring about constant change and improvement in the care. And so my example, what I want to touch on is I am learning when I'm challenged. So that was a challenge to me. It's like I could have taken it as a, oh my God, you've just ruined my life. You know, I've spent 5 years in a residency, and now you're telling me we've got it all wrong and we have to do it differently. And I've learned to take those challenges as an opportunity for growth myself and to see the growth in the person that's challenging me. So when someone is saying you've got it wrong, to me, a white, heterosexual, privileged male, that's a great moment, opportunity for learning. And so that empowers me, and I think it then becomes reciprocal as a leader if I can learn from that, and I can then adjust how I'm engaging with people who have spent long time learning something, and then you're telling them you have to unlearn it. So now, turn it back to you to go over the task.
Yeah, so now, as I mentioned, we're going to ask you to turn and talk to someone who you have not spoken with yet. Make a new friend. That's part of, I think, why we're here. And describe either a time where something made you feel empowered or you felt like you were able to empower someone else. So we'll give you like 5 or so minutes.
I'm not really supposed to talk at these events, but I will share one example. And it's an example where I had worked with a large group of people and we'd brought forward a vision, but within the senior organization, there wasn't a buy-in to that. But it was an attitude of, okay, fine, I will, down the road, seek your forgiveness because I'm not getting your permission now. I'm not seeking your permission. And we moved ahead and we did amazing things. And I won't share the specific example because there is a person in the room who walked that path with me. And there she is. So Brenda Restuel and Carol Hopkins walked that path with me where we did amazing work together, but eventually we got all kinds of kudos for it, but the system wasn't acknowledging what we were saying, so we just carried on.
So failing forward, that's one of the ways that I think that's a really important way to lead, and sometimes as leaders, I think we feel like maybe we don't have permission to do that, and we're going to get sued and all that kind of thing.
My name's Christian. I'm with the Basel Center for Mental Health Law. One of the things that really sticks out to me is the diverse perspectives that I've just been very privileged to attend each of the tables, I guess, and just see conflicting views. And it's been really important for me to have my views challenged. I come from a very I'm actually not even going to mention it, but yeah. And just remembering, take space, make space, but also reaffirming that take space, because there have been some ideas that have been reaffirmed here for me, with regards to guardianship and unaccompanied homeless youth. And so just remembering that, being in these spaces to stand up for those populations, it's really important. And so I'm really appreciative for this opportunity.
We got another volunteer.
Behind.
Hi, I'm Allie Ferguson from the Scattergood Foundation, and my moment was actually with Dr. Evans. So like 10 years ago, 12 years ago, he asked the foundation, would you fund Spanish manuals for mental health first aid? And somehow we said no in the meeting, and somehow at the end of it, he was like, we're gonna have 10% of Philadelphians trained in the next 2 years, and Allie, you can figure this out. And I was like, sure. And so that really was like one of the first big projects of my career. And it was right time, right place. I think trust between our organizations really led to that. But it was like, we went in thinking it was like a really straightforward request. And then it turned into what is now Healthy Minds Philly and a huge initiative. I think 12 or 15 people still work under that. It's a department or a unit within department. So I always think back, like if we didn't have that meeting that day, what would be there now? So.
All right, thank you all for sharing. These are going to be really important examples that Peter's going to get to, but I'm going to bring us back to kind of what we're facing when talking about the mental health of the mental health workforce. So as everyone in this room knows, we've been seeing climbing distress and mental health challenges everywhere, but including in the US, to the point where prior to the pandemic, right, we saw multi-year decline in life expectancy related to deaths of despair, suicide, opioid, and alcohol deaths. And then COVID happened, and that created a lot of different problems and real distress. And obviously everyone in healthcare, right, no matter where you worked in the healthcare system and healthcare settings, the pandemic impacted you. And this includes people who worked in mental health, right? They were navigating their own pandemic experience, their own grief and loss and challenges and what it was like to live during that time, and at the same time witnessing and trying to provide support to so many people who were confused, who are still seeing increased distress, and just how do you navigate both of those things at the same time with really limited resources? So they're really, I think sometimes we talk about the mental health of the healthcare workforce, and we don't talk enough about the mental health of mental health providers. Because when we talk about all of these workforce issues, they're the ones who are experiencing it most deeply, right? They're face to face with the workforce shortage. We talk about, all of these therapists, like you call people, no one gets back to you, but you're a person, right? I think everybody who's in this field wants to help people. And I think coming up against the boundaries of your capacity in this high demand time is really hard. So you have those things, but then if you're working in a setting, right, you have unfair caseloads, unfair management practices, low reimbursement rates, and inadequate wages, and then for a lot of people, high student loan debt, right? So there's all of these problems. And I think the other piece too is that a lot of people in mental health are disincentivized from talking about their own mental health for interpersonal and structural reasons, right? So if you're in the workplace, you're facing, I think, an added level of stigma and discrimination because even internalized, right? If I work in mental health, I should be able to deal with these things by myself. I have the knowledge, right? And I can't show anyone that I'm experiencing distress, whether it's my clients, the people I'm supporting, my management, because I don't want them to think that I don't know how to do my job. I think that there's also structural discrimination that I think is really important to mention. To Peter's point, right, a lot of academic training will tell you do not disclose your mental health challenges. It's part of it, right? And then the structural piece of even from the get-go, so I have a friend right now who is a person with lived experience. I'm a person with lived experience. She's went to social work school. She's trying to become a licensed clinical social worker. She put as part of her application that she was a person with lived experience, and now she has to disclose all of this additional information about herself, about her medical care, about I have to come and talk to you to see if I'm fit to provide support. So I think even from the get-go, from your training, from licensure, you're really trained to think, okay, I can't talk about this. And And the ways, people, I think the way that folks are trying to get around this, and I think someone's question was about this, is like, you can tell people to do self-care, you can tell people to have boundaries. I work a lot with high school students and young adults. I was doing a session last night, and they were like, there's only so many times I can tell someone that they should like drink water every day, right? It's like these practices within organizations and these policies are much bigger and much more profound than a lot of the things that you can do for yourself. I think when we're we hear about the mental health workforce shortage all the time. I think there's three major things that people often point to that also show up as real barriers that we need to address in the work, like some of what Peter is doing. So one, I think engaging youth. One is paraprofessionals and peer support, which we talked about, and then the other is diversity and equity in the workplace, right? So we know that many providers, especially psychiatrists, are getting older, many of whom are going to retire, and we need to bring more young people in. And there's a lot of young people who want to work in mental health for good reason, right? We know that there's really high needs. They're seeing the distress. They lived through the pandemic as a young person. They're seeing it in their peers, and they want to go into the field, but they know, right, the issues of high student loan debt, right, low wages, and they're having to consider, like, am I going to pursue a career where I hear all of these horror stories of burnout with my time, even though I want to make a difference in mental health? And the second piece that we heard about a little bit is peer support and the paraprofessional workforce as building capacity and filling gaps. Yes, but I think also as a means to really transform how we support and empower people who are looking for help. But they also have a lot of unique challenges in the workplace, right? If you put people in a different job, in a setting where no one has training on that job, they get pushed into roles that are not the peer support roles, right? We're not investing in the abysmal wages and rates that peer specialists are paid. We're not investing the upfront money that it takes to transform culture, to bring in a new provider type designed to transform culture. They're often experiencing stigma or discrimination from staff, right? Especially if you are in more of a crisis setting where staff may harbor some beliefs because they're constantly seeing people in crisis, like people don't get better. And then if you think about, we talked about rural mental health, right? Some people with lived experience working as peer supporters are working in settings that they were using services in, and that brings up also different dynamics. And we know that again, when people are coming into the field, there's also really few career paths and opportunities for them to advance. And I think finally, this diversity and equity is a really important issue, right? The mental health workforce is overwhelmingly white, overwhelmingly women, and there's a lot of talk about investing and supporting people and getting into the workforce, which is really important, but at the same time, again, we're not adequately investing in the anti-racist practices, in making sure that we're actually creating safe environments for people to come to work in where they will not be harmed and they will not burn out and have to leave, because there is a lot of data that is what will happen. So I think our major issues in fixing the mental health of the mental health workforce, right? Some of them are these massive policy things about making sure people are paid fair wages for doing really important work, making sure that we have, in considering how to pay for things, the upfront money to do the cultural change. Otherwise, you're really kind of dumping people into cultures that are going to harm them. And I think that is unfair. I think that we are not considering sustainability when we do things like that, right? All of this exciting stuff has happened during the pandemic. Peer support has gained attention and traction that it's never gained before. We're putting emphasis on training, on different scholarship programs. But if we're not changing the culture that people are going to work in, it's really kind of like harming people who want to help. And we're not really going to change much of anything. We're going to put a lot of resources in there. I think I can speak specifically to the world of peer support, where it's like you train people, you welcome people into this really like potentially transformative role, and then the wages are so low, the conditions are so bad that people aren't often staying in the field for extended periods of time. So in addition to all of these larger issues, I think the day-to-day, right, it's the policy and then the practices from the day-to-day that are how we make things sustainable, because everybody wants to enjoy their job. Everybody wants to go to work and be respected. I think right at the end of the day too, the point of working in mental health is to be able to support other people's mental health. And if your mental health is not supported, it's pretty hard to support other people. So all that said, it's an exciting time for the workforce. It's an exciting time with all of this new attention to bringing young people in and addressing racism and increasing diversity and making sure that we have peers and access to peers and these broader policy issues. And then I want to turn it over to Peter to talk about when we're figuring out all of these things, how do you as an organization bring in, like you talked about some of the empowering experiences that you've had and how good it feels and the change that you see in people when someone believes in them and respects them. And how can we make sure that that is the standard for the ways that we interact with one another so the mental health system and workforce is promoting mental health for everybody who's involved with it. And I'll turn it over to you, Peter.
Thanks, Kelly. So I noticed that there was a comment in the chat earlier on, and I won't name who put this out here in case they don't want to be named, but and the question was, is provider burnout an individual issue, or is there a huge flaw in our system that results in burnout? And I answered, perfect question. You know the answer, I think. Yes. So obviously, it's not a personal thing, and I am often disappointed to see that the response to burnout is to support employees to go get therapy or to take care of themselves, or maybe they need to go for a walk or something like that, because that's a offloading of a structural systemic problem in our care system that's blaming the provider for a system that is incredibly broken. So thank you for setting up, Victor, for setting me up with a great question. So I'm going to talk a little bit a few solutions, but there are so many solutions that all of you have to these structural problems. So I'm hoping you'll have a chance to connect when we do another table exercise on what are the solutions to the structural problems that are leading us to have a workforce that's really strained, overburdened, burning out, where we just can't seem to get enough providers. So think about that while we're talking, and I'm going to show a video in a few minutes that shows the experiences of people that have gone through the transformation that I'm going to describe briefly to you. In one of the smallest Canadian provinces on the far east coast of Canada, Newfoundland and Labrador, I had the privilege of working for 25 years at the university there. I did some work across the province. I was always cognizant of the fact that in this province with vast rural isolated regions, there were many people that had no mental health resources. Well, in fact, they had a lot more mental health resources than many big cities do. And it was through a failed research study. I had to go through this discovery and failure to learn that there was gold out in these communities. So what happened was we couldn't get enough participants. We were trying to test out a self-help method that nurses or physicians or whoever there happened to be in these tiny communities that were health providers could distribute to their patients to help them with their mental health. They were so burnt out, they were so overworked that they didn't even have time to sit down and do some of the administrative work to get the study going. So then I tried to publish this report of this failed study, because sometimes it's really interesting, why does a study fail? And most of the journals came back and said, well, your methodology was flawed. And that didn't seem right. Finally, I got a journal that agreed to publish a commentary. And so we wrote up a little bit about what happened and the structural problems. And the editor said, well, what would you do differently? and I was sitting out on my back patio, and I was reading about some of the work in the UK on stepped care. And I said, well, maybe we need to think about what constitutes care much more broadly, to incorporate informal resources that exist in many of these communities into our care system. And then, a few months later, I was thinking, well, forget about rural Newfoundland. What about in the place where I work, a counseling center, where our staff are feeling burnt out? They're not happy. They carry so much burden of the vicarious trauma of the students they're seeing. Our wait lists are too long. And so I said, well, we need a stepped care model. So the stepped care model has evolved over time, because every time I connect with a group like this, we learn there are more resources to add to it. So the model is not a cookie cutter. It's more of a framework for organizing all of the existing natural, informal community resources that are culturally relevant to your community, and braiding them in and integrating them with the formal supports. And one of the things that's especially important is that there are small positive impacts for both the provider and the help seeker all along the way, because our system is built not on a recovery model, but more on a sort of cure model. And I was trained as a psychotherapist to spend a lot of time getting to know people before I could help them. And then I was trained in the Eurocentric approach, which says ask 10 pages of questions so that we can diagnose them based on our amazingly scientific techniques that drew from undergraduate white males on what is the best form of treatment. And I knew there was something wrong with this. And I learned from two women in rural Newfoundland who I watched a television broadcast of their experiences after losing their husbands to suicide. And this region had a rash of suicides over a short period of time, 8 suicides maybe for a population of 1,200 in about 8 months or something like that. And the response to this was, as you might predict, government and others were concerned, and they came in and they said, well, we need to make sure that we identify people that are at risk. And these two women said, no, that wouldn't have worked for their husbands. Their husbands wouldn't have stepped forward at the time of when they were in crisis. They said, what we need is access for everyone immediately, same day, for little small things upstream. So this model really emphasizes getting immediate care, like 988, but not a whole lot of barriers and bureaucratic procedures to go through before you get care. So I often say care first, ask questions later. Don't do long assessments, but just start with what's top of mind. What's really helpful about this approach, we're discovering, now we haven't researched it, but we know that some of our methodologies are flawed, and we should actually just pay attention to what we're hearing in a lot of places where they're doing this work. And what I hear from providers is this approach works for them too, because a one-at-a-time therapy approach is aimed at getting a win almost immediately, a small win. And in fact, they will often start a session by saying, my goal is to have you end this period of time that we're with, whether it's 10 minutes or 20 minutes, that you'll walk away saying that was worth my time. That's how the goal setting starts. And so when you can produce an encounter, every therapeutic encounter has a small win, the provider feels good too. So I think that's one of the structural flaws in our system, is that we're not infusing enough hope in the possibility of having some small wins. We don't have to fix everything in everybody's life. So why is it in our assessments that we ask them to tell us everything that's wrong with them? Go through the list. Check off every single symptom you have. Does your family physician do that? No. So that's structural stigma built into our system that says we have to turn over every stone, find out everything that's wrong with you from a Western Eurocentric point of view, diagnose you, and then somehow that's going to lead to a treatment that helps you. Whereas the research says diagnosis doesn't inform hardly any treatment. There are a few exceptions to that, And, and we do need to ask questions and diagnose at certain times. But our argument is start first with what's top of mind. And if that doesn't work, then we can go to asking more questions and diving down. So this model is about transforming and expanding the workforce. And I mean that in several ways. Transforming the existing workforce to practice in a more flexible way, and then expanding it to include peer support, mental health allies, natural community supports. There's one in central Newfoundland. It's a women's support group called Knit and Talk. Well, or Stitch and, but I think we'll stick with Knit and Talk. And so, why can't we include that on our menu, on our buffet of services? Well, I can tell you why, because the risk managers are going to come in and say, what if there's a pedophile in the basement and you're going to get sued? So we do have to push against the risk paradigm. We have to talk to the legal folks that tell us that we can't do this kind of work. We have to show them some ideas of where it is working, where taking some of these risks are working. So the solutions are to teach skills, to apply to our existing workforce, to apply recovery principles to have immediate small impacts, equip the workforce with expanded toolkits and resources so they don't have to do it all. Part of burnout is because the expectations are so high. Someone has waited a long time to see you, and now they're in care, and you don't want to discharge them from care because they waited so long. Oh my God, what high expectations for a provider that you have to somehow do everything because they took them so long to get here. So instead, we need a system where you can drop in and out of care very easily, like in places that have lots of primary care, and I know there are challenges in Canada and other places where even getting a primary care physician is difficult. But what we need are people that are available, that are generalists, whether peer support or licensed, that can be available to deal with some top-of-mind things. So there's really no need to wait for mental health, because in our communities we have healers, we have elders, we have I won't get into this story about the trainer at my local gym, who I now see as a mental health provider because he changed my life. And so how do we organize all of these folks into a care system? And the model that we're thinking of allows you to do that. You can do it. You can represent it on one page. We call an exercise that we do in working with leaders, and this is important too, that you don't just need to help clinicians develop new skills or bring in a new workforce. You need to work with managers to understand how to structure their workplaces in a way that is quite different from our broken system. And you need to talk to decision makers to get them excited about the possibility that you can put in a framework and a structure that organizes natural, informal, and formal resources. So some of it, some of the transformation, a lot of it has to be at this structural level, because if I just go and talk to one clinician and they're going back and working in a workplace that doesn't recognize or value thinking much more broadly on what constitutes mental health and who are the players, who are the workforce, then they're still going to be holding the bag and the burden. So I want to, in a few moments, show a video. You're going to see staff from this city at George Washington University. They worked there. I don't know if they're all working there now, but they worked as they were transforming their model to Stepped Care 2.0. They were the first university in the U.S. to implement this model. And what you'll see is, they were trained in a one-at-a-time method. So they had a triple-digit wait list, and overnight that disappeared when they introduced this walk-in one-at-a-time model. They developed a broad range of resources along a stepped care continuum, so that the private providers didn't have to do it all. They could prescribe some of the formal and informal resources. and empower the students to do some of these things on their own and drop in again if they needed some coaching. So ongoing therapy became something that you did if this didn't work, or in your clinical judgment, if you knew that this wasn't going to work. What we estimate is that 80% of people can benefit from a non-therapeutic, who are coming, seeking counseling or therapy, can benefit from a one-at-a-time approach, or that also includes support of a suite of resources. That then frees up specialists and psychotherapists to focus the longer-term work on the 20% that need more. But currently, most of our systems are one size fits all. We're going to send everybody to a therapist and hope for the best, and the therapist goes in with the assumption that they'll probably have to have people come multiple times before anything positive or any outcomes will occur. So as you're watching this video, I want you to look for signs of how that workforce is doing now. Do they look like, when they're talking, that they're burnt out or overwhelmed? Do they look hopeful? Or do they look numb? Do they look engaged? So look for signs, and you'll also hear a few hints about what this step care model is. And Holly, you could probably say a little bit about a webinar that if you wanted to learn more about this model on November 15th, I think all of you would get an invitation, isn't it? Everyone here will get an invitation. So I haven't talked about the model, but I just want you to see how these staff talked about their experiences in the transformation. Oh, and sorry, before we go, your table talk then will be, to what are your reactions to this? Is this, is this believable? Do you have questions? What are you curious about? And what did you see in the conversation?
With the step care model, being able to show them that we had flexibility and we could utilize a lot of resources. I looked forward to it because it was something new and it was something different. And as I said, it also gave the client empowerment as well as myself.
Healing, growth in wellness is not a linear process. It's not a rigid process. It doesn't have to look like one thing. It can look like multiple different things. And just the embodiment of that and being able to embrace that, it doesn't have to look a certain way, gives a lot of room and just can relieve a lot of pressure and how they want to kind of move in this particular space of their experience.
Everyone having a little niche, everyone being able to put in a certain way and not have to just try to fix themselves into one type of structure, but really fit themselves into what is naturally there, and then it just thrives.
What is something else we can do? I think once you open yourself up to the possibility that there's a lot of ways of meeting people's therapeutic and mental health needs, then you feel less pressure about trying to figure out how to do it.
We understand the relationship to step care with equity and inclusion, identity, and truly meeting people's needs from an individual standpoint as opposed to doing what it is that we're comfortable with.
Step care helped me learn to decenter myself. It helped me learn to decenter one-on-one therapy. It helped me learn to expand to a community, to a collective, and to make sure that the dependency is not fostered. Agency is, empowerment is, the ability to articulate is, to have self-awareness and know how to use that. That was really useful.
Taught me to think more complexly and think more intentionally.
Encouraging empowerment and helping people to shift from a little bit of a passive approach to therapy. I come and I receive, and more of I have stuff I'm working on. How can you be of support to me, and how can these other resources be of support to me?
We spent a lot of time finding common ground with our colleagues on the campus, really talking with staff and faculty around, the shared mission that we have in the community helping people learn and be their best.
There has to be team buy-in. And I think I've always worked with leaders in those kind of units, and they've come to that work with a willingness to continue to change and grow.
For me as the therapist to show up with my intersecting identities of privilege and oppression, and the client to show up with theirs, and for us to collaboratively work together as much as we possible to come up with a plan that works for them. And I think that it breaks down barriers, it breaks down walls, and it allows them to be themselves. It allows me to be mostly fully myself. And I think that is a winning combination for healing.